So the day 2, we will start the Hall's Affair 2 with our talk, Diagnostic Accuracy through Retinal Imaging. First talk is yours, no? Okay, so I invite Dr. Praveen Murali to deliver his talk on unwinding the twist in macular edema.
So first I'll start with the most common thing, the bread and butter of our retina practice. So that's diabetic macular edema. So this we see in and out of our practice. So we divide into center involving, non-center involving. So the non-center involving are the one with good visual acuity. So these are the one where there are two school of thought whether to observe or whether to treat the patient. So since they have good vision and the progression over years time is less than 15%, so there is not it's not an urgency to treat such patient. You can ask the patient for a good glycemic control, do a lipid profile. A lot of them they have hard X rates, so you can send them to a physician. And once everything is under control, maybe you can. This is one of the indication where you can do lasers, focal laser. You can either do an angiogram, see the leaking aneurysms or hit the aneurysms, or you can directly target them under direct visualization. The center involving, as such, we don't have much issue. The standard line of treatment at present is anti-VEGF. The indications of steroids are few. Some of them give in naive treatment also. But otherwise, in a vitrectomized eye, you can go ahead, or in patient with antithromboembolic phenomena within 3 months, you can go ahead with the depot preparation. And the other confusing thing is when you have PDR with 6/6 vision and non-center involving. So in this case, in case you're advising laser, there is chances that the non-center involving CME can or DME can involve the center. So here, either you can go ahead with the anti-VEGF treatment followed by laser, or if you want, you can directly go ahead with laser if patients are not willing. And then once the vision drop, maybe it's little dicey how to take a call, but then you can decide on patient-to-patient basis. When there are big vessels which are elevated, in such cases, giving anti-VEGF again is a confusing situation. So in such case, you can go ahead with lasers directly. Maybe you can keep one or two half this this diameter away from those elevated NVs, so that you prevent formation of tractional detachment. In case of asteroid halosis, may be difficult to see those NVs in the early stage, so you can do an angiogram, and in case there are NVs, you can directly go ahead with the PRP pattern. Or if there is only a CSME in such cases, then you can treat accordingly. DME in pregnancy is always tricky, dicey how to treat. Anti-VEGF as such should be avoided because of you can have some issues with the fetus or the developing embryos. So if it's in the last trimester, maybe you can observe for 1 or 2 months. Post-delivery, there are chances that the DME may resolve. However, during the first or second trimester, if the vision is progressively deteriorating, you can consider giving intravitreal depot of steroids. You should inform the patient about the chances of cataract and glaucoma well in advance. So just seeing the OCT, we should not come to a diagnosis and treat such patient. So when you just see this OCT, you may have, if someone refers a case or someone because of the online procedures, online diagnosis and all, online opinions taken, just seeing OCT, we should never come to a diagnosis and start treating the patient. You should have an overall view. So this was a patient with malignant hypertension. So one of the subtle feature or early signs of a malignant hypertension is CS detachment at the macula. So if you can see a detachment without a disc edema, we can consider them as malignant hypertension, and you can, even if the BP is low, this is one of the subtle signs we can recognize and send them to physician for getting the underlying BP controlled. To treat or not to treat is again a debate. I think so. Most of this patient, once you control BP, the edema resolves. However, there are a lot of other small studies, not large series, where bilaterally one eye was given intravitreal steroids or intravitreal anti-VEGF. The one with intravitreal steroids or anti-VEGF given, the contrast and the patient perception was better compared to the other eye. The other thing which can get confused are IGTs. So if you can see clinically, you can see those fuzzy, hazy margins. In little more advanced case, you can see pigments. Once you see pigments, the diagnosis is quite obvious. Our OCT in the early phase can pick out all those subtle signs, and yeah, these two are like a very classic case of IGTs. This also is for the general people may confuse, but I think so most of the retina people will identify very easily about the optic disc pits. So they have one of the causes of multi-layer schisis in, you can see schisis in all the layers. So one of the diagnosis or classic diagnosis optic disc pit. Other thing, something like dome-shaped maculopathy, where in case you see a dome, then don't just consider this as CSR or any other thing. So you should remember such pathologies also. And drugs, there are many drugs. This is one of the most commonest one. So if you can see fine crystal, go ahead with history. If you can ask in detail, you can get the history from the patient. Same thing with inflammatory conditions also. If you just see the OCT or thing, you may have a edema, but if you see peripheral area, you can get a pars planitis or vasculitis, which can give a DD for your macular edema also. If patient had a recent surgery done, pseudophakic CME should also be kept in mind. Treatment as such, we have, you can go ahead with topical steroids or topical non-steroidal drugs. You can even consider giving PSC if they are not resolving. So the holistic approach is always required. Don't just go by OCT. So just a macular edema on OCT, but however, when you see a fundus picture, you can see a big patch just superior to the fovea. So retinitis patch investigated, came toxopositive, and was treated for the same. A few other conditions like RP can have CME-like picture. Okay. Yeah. Thank you.
Thank you, Dr. Praveen.
Now I request Dr. Divya Alex to present the next talk, Ready Reckoner on wet AMD, RAP and PCV.
This one. Good morning, everyone. So, when a patient presents to you with this kind of clinical picture, you can possibly give some professional diagnosis, whether it is wet AMD, the type 1, 2, or 3, or it is the other end of the spectrum, the polypoidal choroidal vasculopathy. So, I am going to take you through some imaging clues to arrive you at the final diagnosis. So, the wet AMD, the hallmark of the disease itself is the choroidal neovascular membrane. Excuse me, pointer, please. No, in this, it's not coming. It's, It's not. See, the hallmark of the disease itself is the choroidal neovascular membrane. So this is the classic case where you can see the deep subretinal greyish-grey membrane with a surrounding neurosensory detachment and the tinge of hemorrhage just surrounding it. This is the classic presentation, but there can be different kinds of presentation like multi-level of bleeding. Multi-level of bleeding, there can be sub-RP bleeding, subretinal bleeding. It can be associated with soft confluent drusen and lipid exudation, or there can be massive subretinal hemorrhage. So this is the type 1 or the occult CNV, where the neovascular membrane is located below the retinal pigment epithelium. So this is the most common type, and in the OCT we identify this as a fibrovascular PED. You can see multiple moderate level of hyperreflectivity between the retinal pigment epithelium and the Brooks membrane. So the exudation usually associated with the occult will be subretinal fluid. Whereas in the type 2, the classic, the choroidal neovascular membrane will be located above the retinal pigment epithelium. That is, it is subretinal. And the classic OCT finding will be the SHRM or the subretinal hyperreflective material seen. And the usual exudative pattern associated with the classic CNV will be a combination of the intraretinal as well as the subretinal fluid. So once you get the intraretinal fluid, the disease course is going to be more aggressive. That is, the subretinal fluid is less clinically aggressive than the intraretinal fluid. And unlike the classic CNV, the occult CNVM has got a less aggressive natural cause based on the presenting acuities as well as the long-term natural history. And you can also get the type 4. Type 4, it is the combination of type 1 and type 2, where you can see the fibrovascular PED as well as the subretinal hyperreflective material. You can see a combination of type 1 as well as the type 2. So the fundus fluorescein angiography usually helps in detecting or differentiating between the type 1 and the type 2. So in the occult, as there is the sub-RP fibrovascular PED, there will be always a stippled hyperfluorescence, the early stippled hyperfluorescence with pooling either with or without leakage during the late phase. Or there is another presentation that is late leakage of an undetermined source, that is LLUS, often presenting as a speckled hyperfluorescence with subretinal pooling of the dye. But the second type, the classic, it is entirely different from that of the type 1. You can see an early lacy pattern and it will be clearly well demarcated margin, increasing in intensity with leakage during the mid and the late phases. So these were the signs of active disease. So you should also know about the signs of chronicity. One sign being the scar. That is, instead of that moderate hyperreflectivity, you can see entirely different type of uniform hyperreflectivity that is called as the scar. And next one is the outer retinal tubulation, and next is the geographic atrophy. So this is the picture of geographic atrophy. You can see there is complete loss of the outer retinal layers. You cannot see the ellipsoid, you cannot see the photoreceptors or the RPE with the reverse shadowing. This is the geographic atrophy, and this is what is called as the outer retinal tubulation. This is the chronic inflammation photoreceptor rearrangement. So you can see a hyperreflective lumen surrounded by a hyperreflective lumen. That is, this should be differentiated from the hyperreflective intraretinal cystic spaces. That is, this will be purely hypo, and in this you can see a hyperreflective lumen. So the outer retinal tubulation, it is a sign of chronicity. And this is the type 3 CNVM, the retinal. This is a distinct form of occult CNVM associated with proliferation of intraretinal capillaries, and this goes through a 3-stage vasogenic sequence. So this is the stage 1 where there is intraretinal neovascularization, and this is a capillary proliferation arising from the deep capillary plexus, and in the stage 2 this further grows and this causes a retinoretinal anastomosis, and in the stage 3 this further grows below the RPE and it forms a retinochoroidal anastomosis. And there are certain classic features of classic OCT features of ROP, the trapezoid PED, the wrinkling of the pigment epithelial detachment, which is associated with intraretinal fluid, and this is the erosion sign. That is where you trace this pigment epithelial detachment, you can see a portion it is eroded, and there will be a hyperreflective material just above this erosion. This is called as an erosion sign. And you can see these two free flaps of the RP that is broken. This is called as a free flap sign, and it will be usually associated with reticular pseudodrusen. So the reticular pseudodrusen, unlike the other drusen, it will be above the RP. And whenever you see other eye reticular pseudodrusen, you should also think about the possible diagnosis of RAP. So here we were talking about the thin choroid spectrum, that is the wet AMD. So this is the normal choroidal thickness. This is the thin choroid with wet AMD, and now we are going to talk about the thick choroid, that is the pachychoroid disorders. So the polypoidal choroidal vasculopathy was first described by Yanusi et al. In 1982. It was a clinical entity distinctive from neovascular AMD, consisting of peculiar subretinal polypoidal vascular lesion with serous and hemorrhagic PEDs. So the classic feature of the PCV is that you can see a thick choroid, and these are the pachy vessels, and the pachy vessels compressing the choriocapillaries. So it can emerge as a hemorrhagic disease or an exudative disease or a combination of both. And there are certain classic OCT features in PCV also, that is the tall peak PED, the thumb PED, the notch, the PED, the tomographic notch. All this presents as a polypoidal lesion inside this RP. And there can be another distinctive feature is the presence of BVN, that is the branching vascular network, which will be seen in the OCT as the double layer sign. You can see there is the retinal pigment epithelium and the Brooks membrane, and in between there is a hyperreflective substance lying between this. So this is the double layer sign, which signifies the branching vascular network. Me and my professors were very lucky to elaborate one distinguishable sign in the polypoidal choroidal vasculopathy, that is the lateral elongation of the flat irregular pigment epithelial detachment. So we described the evolution of the disease through this. So this was the flat irregular PED, and this is a quiescent disease, and once it starts elongating, slowly the disease is starting with the formation of subretinal fluid and IRF, and you can see at the end of this there is the formation of polyp. So this is the quiescent disease, and after a period of time the polyp is developing at the end of the elongated flat irregular PED. So as fundus fluorescein angiography helps in the type 1 and type 2 FFA, ICG lots helps in diagnosing the PCV as well as the type 3 RAP. So the classic features will be early nodular hyperfluorescence arising from the choroidal circulation arising in the first 6 minutes, and the branching vascular network appearing within the first minute of dye injection. And the ICG in the RAP, and you will be seeing a hotspot at the center of the PED, whereas in PCV it will be usually at the edge of the PED. So the talk will not be completed without the OCT angiography. So these are the different types of pattern that you can get in wet AMD, that is the Medusa head, whereas there's a central feeder vessel and centrifugal vascular trunk, and the C-trunk pattern with an eccentric feeder vessel. So usually the type 1 lesions are larger and less demarcated compared to the type 2 lesions because they are sub-RPE. Type 2 CNVM usually smaller and they have a glomerular appearance, and higher flow indexes will be usually associated with the type 2 or the classic CNVM. And OCTA in RAP, it is usually dictate the retinal anastomosis from DCP very clearly. And the tough-shaped high-flow network will also be seen even in the B-scan as well as in the OCT angiography. So in PCV, just the octa, you should be knowing that ICG delineates the polyps better, but OCTA will delineate the BVN better. So these are the diagnostic clues which help in demarcating these three diseases. So thank you once again the KSOS and scientific committee for this.
Thank you, Divya Alex. Now I request Dr. Indu VP to present her talk on stars in sky dystrophy dystrophy or acquired?
Good morning, everyone. I thank Dr. Divya Alex for this opportunity. Now, coming to the topic proper, stars in the sky, dystrophy or acquired. So basically, stars in the sky means dotted lesions on the retina. Dotted lesions on the retina mainly fall into 5 main categories. These are the flecks, drusen, Whitley-form deposits, crystals, and inflammatory lesions. So you have plenty of diseases with dots in the sky, with stars in the sky, and how do you differentiate? Differentiation is based on history and course of the disease, clinical features, multimodal imaging, and ERG or EOG tests. Now, we go into one by one in detail. Now, if you have a patient with a positive family history of night blindness, and clinical picture showing plenty of yellowish-white lesions on the retina, and ERG showing rod dysfunction, you are mostly dealing with a condition called flex. Now, flex can be, so the first question that you ask when you see flex is whether it is macula sparing or macula involving flex. Now, flex sparing the macula mainly fall into 4 main categories. So how do you differentiate between them? Now, if you have a person with a normal visual acuity, there is no history of night blindness, ERG is also normal, but however, on fundus examination, you see discrete, small flecks distributed throughout the mid-periphery. You are dealing with a condition called a benign familial flecked retina. It is a non-progressive condition. Here, everything is normal except that on fundus examination, you see flecks. So here, these flecks are hyperfluorescent and autofluorescence. And on OCT, you see mild thickening at the level of the RPE. If the patient has history of night blindness, which is not progressive, that is stationary night blindness, and however, on ERG, patient shows a delayed decreased scotopic ERG after 30 minutes, but which normalizes after 2 hours of dark adaptation. That is, the patient has got a delayed dark adaptation. And if you see plenty of flecks in the mid-periphery, you are dealing with a condition called fundus albipunctatus. It is actually a disorder of visual pigment regeneration where recovery of normal rhodopsin takes much more longer time. Now, if the patient has progressive night blindness, peripheral field loss, and ERG shows both rod and cone dysfunction, and along with that, patient has got an optic nerve pallor with attenuation of blood vessels, that is all features of RP, but instead of the black pigments and you see whitish flecks in the mid-periphery, you are dealing with a condition called retinitis punctata albicans, which is mainly RP with white flecks. Now, here again, you can see cystoid macular edema similar to that of RP. Now, if the patient has features of fundus albipunctatus, that is stationary night blindness, delayed dark adaptation, but instead of smaller flecks, you see larger flecks on the retina, this is called as a flecked retina of Cantori. Now, sometimes patients can present with the features of night blindness and peripheral field loss and all, and you see along with that, on systemic examination, you see corneal cirrhosis and bite-out spots, history of inadequate dietary intake or malabsorption. You might be dealing with a vitamin E deficiency syndrome, and this is called as fundus surophthalmicus. Usually, after supplementation of vitamin A, these flecks disappear. So these are the important diseases where the flecks spare the macula. Now we come to the flecks involving the macula. These are actually the true flecks. It mainly falls into 2 main categories. One is the Stargardt's disease and the other is the fundus flavimaculatus. They have a few common features. That is, these flecks are triradiate and they will be intensely hyperautofluorescent, and patients may have a dark choroid and fluorescent angiography. So how do you differentiate? Stargardt's disease is mostly visual involving because of macular atrophy. It has got an earlier onset and there is faster progression. Whereas flavimaculatus, relatively later onset and slow progression. Vision may or may not be affected, may be affected if there are macular flecks. Now, macular flecks can also be seen in a few systemic diseases like Gellin syndrome, ring chromosome 17, and Alport syndrome. Now, coming to the next differential diagnosis, drusen. So, basically, how do you differentiate between a drusen and a fleck? Drusen are usually a later onset and it is progressive, more yellowish in color, rounded, and it mostly situated in the macula. Autofluorescence patterns may vary, and OCT shows it is at a sub-RPE deposit. whereas flecks are usually early onset, mostly stationary, more whitish in color, smaller and regular pattern, may involve macula as well as the periphery, and usually hyperautofluorescent, and OCT shows a thickening of RPE with impingement of the photoreceptor layer. So you have different types of drusen, soft drusen, hard drusen, cuticular drusen, etc. Now hard and soft drusen, as you can see here, hard drusens are usually smaller and soft drusens are larger. Autofluorescence not very significant, and on OCT you can see that these are sub-RPE deposits. But a cuticular drusen is a characteristic, the fluorescent angiogram of cuticular drusen is a characteristic starry sky fundus. You can see plenty of whitish lesions in the retina, and at OCT this is a characteristic picture showing the saw-toothed appearance. Reticular pseudodrusen, these are also subretinal deposits instead of the sub-RPE deposits. And on the fundus picture, you see very small, minute lesions which are distributed throughout the macula. And on OCT, you see that these deposits are subretinal and not sub-RPE. Drusen, in addition to age-related drusen, you can also have drusens in hereditary conditions like Malaysia leventinese as well as in MPGN type 2. So these patients will have renal disease also. Now coming to the third differential diagnosis, that is the Whitley-form lesions. Multifocal Whitley-form lesions can also be seen. They may be seen in Best disease as well as in certain other conditions like malignancies. So the most important how to differentiate, they are very intensely hyperautofluorescent like this, and you can also see larger subretinal deposits. And EOG is one of the important confirmatory investigation. Patients with an abnormal EOG will have Best disease. Now coming to crystals, crystals can also produce a starry sky appearance. They may be hereditary or they may be drug-induced. Now if the patient has plenty of glistening, these are glistening yellow deposits throughout the fundus and sometimes crystals in the cornea also, without any systemic disease, you're most probably dealing with a condition called Beatty crystalline dystrophy, which is a hereditary condition. Now here on autofluorescence, you can see multiple areas of atrophy, and on OCT, you can see reflective lesions. These are actually the crystals which are located throughout the retina. Crystals can also be associated with systemic disease like Sjogren-Larsen syndrome, cystinosis, primary hyperoxaluria. So these patients may have, in addition, systemic findings also. Drugs can also produce crystals in the cornea, like for example, nitrofurantoin, tamoxifen, and talc. Inflammatory lesions can also, especially the white dot syndrome, can also produce a starry sky appearance. So what are the clues? They may have associated flu-like illness. Inflammatory signs may be there, like presence of anterior chamber cells and Witt cells. OCT may show patchy outer layer loss as well as subretinal fluid. And the multimodal imaging helps in identifying the diagnosis. So a few examples like mutes, punctating choroidopathy, and APMPP. All these will show whitish lesions in the macula, whitish lesions in the retina. And on the characteristic feature is the ICG. ICG, you can see multiple hypofluorescent lesions on the retina, which are the choroid granulomas. And autofluorescence is another important another important investigation which helps you to identify the diagnosis. So the take-home message is take a proper history and do a proper clinical examination. Multimodal imaging and the electrical test will help in identifying the diagnosis. Thank you.
Thank you, Dr. Indu. That was such an informative talk. I invite Dr. Divya Balakrishnan ma'am to deliver her talk on cause of diagnostic confusion.
Good morning, everyone. At the outset, I would like to thank Divya Alex and KSOS for giving me this opportunity. So my topic is posterior scleritis, a diagnostic dilemma. Posterior scleritis, as you know, is a very rare entity, but it is potentially sight-threatening uveitis, which affects the posterior segment of the eye. And it has got a female preponderance, which affect all age groups. Why is it important to diagnose this? Because this, if we diagnose early and treat, it may prevent the potential severe complications which this can lead to. So it's actually inflammation of the sclera posterior to the ora serrata, and there may be associated inflammation of the choroid and the retina. So it occurs either because of a scleral vasculitis which causes inflammation of the sclera, or maybe because of the autoimmune reaction against the scleral collagen or glycosaminoglycans. Posterior scleritis can be of two types, which is nodular posterior scleritis or it may be diffuse. The diffuse variety is most common. And when you see a case of posterior scleritis, always you should look for a systemic association. 30 to 50% of the patients can have a systemic association. So that is the important aspect to diagnose this entity. So the etiology, it could be because of immune mediated or it could be infective. So immune mediated usual entities which we come across are rheumatoid arthritis, ankylosing spondylitis, psoriatic arthritis, or secondary to vasculitis like polyarthritis nodosa, vaginous granulomatosis or Behçet's disease. Infective, the most common being tubercular or syphilitic entities or other viral entities like herpes zoster or herpes simplex can also present with posterior scleritis. The patient usually present with a history of pain and usually early morning dull boring pain, and pain may be on ocular movements also, and they may present with defective vision. They can have presentation of mild proptosis and congestion. On examination, you will see there will be a scleral congestion, especially more so in the diffuse variety. In the posterior scleritis, you should raise the lid and look for this congestion. And anterior segment, they can have an shallow anterior chamber, especially when these patients are associated with a peripheral choroidal detachment. They can cause a secondary angle closure. They may present with acute angle closure like kind of a picture. So it's very important to differentiate acute angle closure and don't do PI in all these patients. So look for the posterior segment also before you diagnose it. And because I told that there is association of systemic diseases, always look for any clinical features of the systemic disease. So why it has got a diagnostic dilemma is because it can present in a very like fundus picture. So as you can see from this picture, it can present with either mild features of vitritis, disc edema mimicking that of NAION, or even bilateral. It is usually very rare. And it is usually unilateral presentation. Very rarely it can present maybe bilateral, and then you should look for like differentials like malignant hypertension, etc. So the usual presentation might have this vitritis. They present with the disc edema, macular edema, and associated retinopathy RP changes. The most common feature being the choroidal folds, which you can see here, and the retinal striations. They can have these exudative detachment, which look like sometimes like a PED, and they may diagnose it like as a CSCR. They can have massive exudative detachment and a choroidal elevation, which looks like a metastasis or a melanoma, and they can have annular choroidal detachment. So because of this varied presentation, this patients might go undetected in the initial presentation. So what are the differentials? As I mentioned, that it could be tumors or it could be inflammatory. So tumors like melanoma, hemangioma, metastasis, lymphoma, and inflammatory like granuloma, VKH, or central serous chorioretinopathy. So the main clue in making a correct diagnosis is a multimodal imaging. So the most important being ultrasound B scan. Then OCT, actually of late we see that many of these conditions can have various specific features. And then FFA, ICG, of course in these conditions we need to differentiate these conditions, and sometimes we may have to subject the patient for MRI also. So this is a typical classic feature of a posterior scleritis, which the investigation we see usually. So this is the ultrasound B scan. When we do, you can see this is a classical T sign which we come across, and the A scan corresponding to this, you will see that there is a high internal reflectivity. So that is one of the classic features of posterior scleritis, and this classic T sign may not be present in all cases of posterior scleritis. So don't underdiagnose posterior scleritis if you don't see a T sign. Sometimes in a localized nodular posterior scleritis, you might see that the A scan shows an internal hyperreflectivity, but there might be a localized posterior subtenon fluid in that area. So it need not be always an extensive T sign which you come across. And in FFA, we always expect a hot disc in all cases of posterior scleritis. That need not be the case in all the cases. In the first picture, you can see that the disc is not that hyperfluorescent, but in the late phases, you can see that there is the leakage and mild pooling of the dye. So if you don't see a disc leakage, again, don't think that it cannot be a posterior scleritis. So this is a classic one which you see that there is an early hypo in that area, and then the slight disc hyperfluorescence. In the late phases, you can see that there is a leakage and the pooling of these dye. So this is a classic picture which you come across in cases of posterior scleritis. And in OCT, again you can see that there will be an elevation of the choroid, the contour will be elevated, and you might see mild thickening of the RPE, but you can still see the choroidal vasculature structures there, you can see the choriocapillaries, and in retina, actually inner retina may not be showing much of a features, but you can see in the outer retina again hyperreflectivity of the outer retinal layers, and there is a hyperreflectivity of the subretinal fluid, need not be present in all the cases, and there is something called a bacillary layer detachment, which is of late described in cases of inflammatory conditions. Bacillary layer detachment is that you don't, here you can see that RP is there and this is subretinal fluid. In this area, when you see that there is still a layer of the retina there above the RP and there is fluid collection above there. So still you see that choroidal features in these cases of OCT in posterior scleritis. So here you can nicely see this choroidal folds in there and the disc edema in this case. And the FFA, which shows that early it started mild hyperfluorescence at the disc and mild pinpoint leakage, and here you can see the hot disc. So OCT, again the B scan and the OCT features which I have already described. So the differentials which come across is the choroidal melanoma. You will see in the B scan the most differentiating feature is the angle kappa in the A scan, where you will see that the internal reflectivity will be low in cases of melanoma. And in OCT you won't be able to see the posterior extent, and there will be a hyporeflectivity in cases of melanoma. You will see that infiltration of the choriocapillaries with the mass lesion. Another one is the choroidal hemangioma. Again, in chronic cases of hemangioma, you will see that there will features of intraretinal fluid and the subretinal fluid, and FFA will show this diffuse hyperfluorescence. And VKH is another condition. Sometimes it can present unilaterally, which can get confused with the posterior scleritis. But you can see these RP undulation. There will be pachychoroid. You will see vitreous cells, and there is increased choroidal granularity. And ICG and FFA actually helps to clinch the diagnosis, where you see these hypofluorescent areas in the ICG, and in the FFA you can see the disc leakage with hyperfluorescent areas. And another thing which can get confused is the choroidal metastasis. Here you can see this, the RP is usually very irregular and undulated, and the hyperreflective material can be there in the subretinal fluid. So this is a case of CSR, which is subretinal fibrin, which might get confused with the posterior scleritis. But here you can see in the OCT, the RP is straight and it doesn't have much of an undulations, but sometimes they can have a small pigment epithelial detachment. FFA actually helps to clinch the diagnosis, which shows a focal leakage. So when you, once you make a diagnosis of posterior scleritis, it is important to differentiate from the infective pathology. So the patient has to subject to the investigations, and the treatment is usually start with NSAIDs and systemic steroids. So it is very important to differentiate posterior scleritis from its mimicus, so as to, you should pick up the systemic association and any life-threatening conditions like any malignancies or a metastasis. And multimodal imaging is the clue to differentiate these one. And early treatment helps actually to prevent the vision loss. Thank you.
Thank you, Dr. Divya Balakrishnan, for that nice talk. I invite Dr. Menon Rahul Radhakrishnan for a controversial topic. Do we really need to panic post-op end-off or sterile inflammation?
So, a very warm good morning to everyone. I would like to thank Dr. Divya for this opportunity. So, I'll be talking about post-op endophthalmitis versus sterile inflammation. So, do we really need to panic? This is a pretty rhetorical question actually. For any ophthalmic surgeon, you see an inflammation in your post-op patient, you are going to, depending on your level of expertise, you're going to panic to a certain extent. So I'll be talking about, three case scenarios. So you see your post-op day 1 patient complaining with redness pain. He or she has an AC reaction, fibrin plus minus with a hypopion, and the posterior segment is quiet. This is the first case. The second case is a post-op day 5 patient with redness pain, AC reaction, fibrin, hypopion, and the media is, the fundus cannot be visualized very clearly. And the third case is, you had operated almost a month back, the patient comes with pain and redness, you have reaction, hypopion, and the media, there's some amount of haze. So, any inflammation within the of the eye, either in the anterior segment or the posterior segment, is called as endophthalmitis. this could be either infectious or sterile. So infectious endophthalmitis could be exogenous when it happens following a trauma or intraocular surgery, or it could be endogenous when it spreads into the eye from a distant source. And the non-infectious causes include when it happens following when the liquefied matter, lens matter, goes into the vitreous cavity, especially after hypermature cataract surgery, or it could be because of intraocular tumor necrosis, post-trauma, or phacoanaphylactic. So the first main cause for sterile inflammation is TAS, that is toxic anterior segment syndrome. So this can happen following cataract surgery, keratoplasty, and even after posterior segment surgeries. So basically, there's an unusual anterior chamber inflammation in the early postoperative period. So what really happens here is the non-infectious substance enter the AC and they cause toxic cellular and extracellular damage. Now, it could be acute, which can happen within days, or it could be delayed. It usually starts a little earlier than endophthalmitis, infectious endophthalmitis. And you will have usually see limbus to limbus corneal edema. Pain is usually very minimal, even if it's present. And the anterior hyaloid is usually quiet. So if you look at for the AVF cells, you usually should be quiet. But if there's severe reaction, sometimes there might be a spillover reaction. So, but one thing you should all know, because what we tend to diagnose is on the onset of symptoms. So if you just see, in the early period, we might diagnose it as TAS. TAS can even happen little later, as it can come as a delayed presentation. So Miyakan group have reported cases of late onset TAS, which have occurred after about 42 to 137 days post-surgery. And to look for a cause is very difficult because Sengupta and group have reported from Arvind's study, what they found was like no etiology could be found in about 52% of the cases. So the ASCRS task force suggested that improper cleaning of the surgical instrument is the most common cause of TAS. So it could happen following a surgical instrument contamination because many times we use ETO sterilization of the surgical tubing that we use, or sometimes inadequate flushing of the handpieces can actually cause TAS. Even if we stay in the capsule following cataract, during cataract surgery, if we stay in the capsule for a longer time, or even the various drugs that we use, if they contain preservative or inadvertent dilution can also cause TAS in the post-operative period. And sometimes the patient's clinical characteristic, especially diabetics, they tend to have severe inflammation post-surgery. So the treatment is, if you see a mild TAS, the treatment is with topical steroids. Moderate to severe, you can give subconjunctival dexamethasone. Severe cases, you might have to start them on oral steroids. Sometimes you will see fibrin in such cases, which is refractory to any treatment. So in such cases, you can actually use intracameral injection of RTPA. If the inflammation is not subsiding with treatment, do not hasten, think it is and treat it as endophthalmitis. Sometimes you can also develop, these patients of TAS can have CME. So in such cases, you'll have to treat it with intraocular steroids or anti-VEGF. Now, endophthalmitis usually presents with defective vision post-surgery, lead edema, chemosis, hypopyon, AC reaction, vitreous inflammation, exudates, and retinal hemorrhages. Now, if you're talking about one investigation which always saves our skin is B scan. So whenever in doubt, even if it's a TAS or it's an endophthalmitis, get a B scan because you have the other eye as a reference. So look at the vitreous opacities. If you see there are more compared to the other eye, if you see more opacities, vitreous opacities in the affected eye, take it as endophthalmitis. You will see a retinochoroidal complex thickening, and also look for choroidal detachment and retinal detachment because it helps us to plan our management. Then once you suspect endophthalmitis, the treatment is you have to take a AC tap, or we can take a vitreous tap, which I'm not very happy suggest a vitreous tap, because what happens is inadvertently we create a traction on the retina and we actually cause much more complications. Vitrectomy, if you really want to take a vitreous tap, go think of vitrectomy, because it has a higher diagnostic yield for culture when compared to vitreous tap. Because many times when you take a vitreous tap, it might be dry tap. Now, once you get the sample, send it for microscopy and culture. Along with that, get a PCR done, because PCR has an increased sensitivity compared to culture. Second most important thing is rapid diagnosis. So if you send the sample for a eubacteria or a panfungal genome, you can get the report within 90 minutes, whether you're actually dealing with the case of endophthalmitis. The only limitation being that you cannot determine what antibiotic you have to use in such cases. So intraocular antibiotics, if you are suspecting of bacterial endophthalmitis, for the gram-positive spectrum, you give it, treat it with vancomycin. For the gram-negative, you can give ceftazidime or imipenem. Even nowadays, we use a lot of piptas, which covers both, and because if you see in the multispecialty model, nobody starts with simple antibiotics. They all go for piptas and stuff like that. So piperacillin tazobactam which is one antibiotic which covers both the gram-positive, gram-negative, and as well as anaerobic organisms. In bacterial, you have to treat it with dexamethasone also, along with the intraocular antibiotics. Also, oral steroid has a huge role in exogenous endophthalmitis. The reason being, the damage that is being done is not just the infection, but also the ongoing inflammation. So you have to take care of that also. So oral steroids, definitely you have to start in a case of bacterial exogenous endophthalmitis. If you're suspecting fungal, you have to treat it with the anti-fungals that we prefer is voriconazole or amphotericin. The treatment is very simple. You can either go for tap and inject, or you can treat it with vitrectomy with intraocular antibiotics, or which plus or minus oil. The treatment has, from a VR perspective, tap and inject is something which we don't prefer nowadays. We see suspect an endophthalmitis. Time is the most important, crucial thing that you have, because any delay in diagnosis, many times, you see it. I would prefer to go inside and do a plain job, do a vitrectomy. That is what we prefer now, unless there is very few cases where we are still dicey whether it's inflammation or it's an endophthalmitis. Might try give a trial of one dose of tap and injection. But if the second it's not subsiding with first injection of antibiotics, prefer to go in. So the three cases that I was discussing about, the first case, I would take it as TAS. Okay, what I'll usually treat it with, I'll increase the topical steroids, start them on a cycloplegic. Probably even if there's severe inflammation, I might also give an intravenous steroid and keep a very close watch. Very close watch means I would not mind calling the patient the very next day or even the day after. And if I feel that the inflammation is not subsiding, I'll treat it as, I will prefer to err on the side of over-treatment and treat it as endophthalmitis. The second case, it definitely looks like an endophthalmitis, either tap and inject or directly go for a vitrectomy and clean the job. The third case is, many times once the patient stops the topical steroids, they might come with rebound uveitis. So restart the topical steroids with the cycloplegic. If there is any history suggested that the patient might be has a history of uveitis, start oral, you do a uveitic workup. But again, in such cases, because you have to keep the element of delayed endophthalmitis also in your mind. So if with a close watch, if you feel that probably it's not improving with treatment, take it as infective and treat it as endophthalmitis. So to just summarize, to diagnose endophthalmitis or stellar inflammation solely on the basis of onset of symptoms is very unreliable. That is something which most of us do. Pain may not be the only symptom. It might not present on all cases of endophthalmitis. And in any ambiguous situation, prefer to err on the side of over-treatment and treat it as endophthalmitis. Thank you.
Thank you, Rahul. I have a question for you, Rahul. Have your management of endophthalmitis changed in the recent past? Have you changed that Cefta Vanco to Piptas?
I have started. I see. When we were during our fellowship days, it was like you see a case of endoph, take the tab, AC tab, started with injection. But now I prefer, if I suspect endophthalmitis, I would prefer to go in directly, start with vitrectomy. I don't wait for they take one tab, send it for culture. It might take another 3 days, 4 days to get the report, and then because time is something I feel is the most crucial factor. So one thing that, and Vancocefta, if it is, I feel it's not a doubtful cases where I'm taking an AC tap, I might try treat it with Vancocefta and Deca. But otherwise, I have tried Piptas, and even for gram negative, rather than ceftazidime, I'm preferring imipenem more nowadays.
Okay, even without a single dose of injection, you are directly going for that early vitrectomy.
Yes.
What is your take on that, DB ma'am?
See, like as Dr. Rahul mentioned, in case the endophthalmitis is severe, like in very suspicious cases, whether it is an inflammation or an infective cause, then only I would go just with an injection. Otherwise, vitrectomy, and then send the sample, then give antibiotic.
Because I also think early vitrectomy does a lot better for the patient.
Definitely, because I have had a few cases where referred endophthalmists to me, where they had taken the tap, they had injected with some antibiotics, gave to me after 7 days, went in, did a good clean job. But what happens is all the inflammation and like I said, the patient was not started on oral steroids and everything, post inflammation, everything. What happens is finally, by the time you go in, many times you won't even be able to do good justice to the job. So one more thing, what I would prefer is, I don't know how everybody has their own this thing. Uh, it's not just about doing a co-vitrectomy. I
Yes,
try to induce
exactly.
a PVD, and probably I might do a clean job. I'm not worried about creating a break. If I create a break, I'll do a laser. I know how to settle the retina, put oil and come, not an issue. But I would prefer to do a clean job.
Yeah.
Every person has a different take on that. I don't know
No,
what DB
I
ma'am would
completely
say.
agree with that. That instead of core vitrectomy, if you do that and if PVD induction and do a clean vitrectomy,
But
that do
there are certain cases I have
Yeah.
burned my hands too. Many times, if I see the retina is very inflamed, I might not induce a complete PVD. I will just induce it, tease it, and then come back. So that probably, I think Dr. Divya might have more experience in that.
No, I mean, like I would also go for a near complete, but I wouldn't like to make any breaks actually, because endophthalmitis and breaks, like many a times the case we lose actually. So, but one of the causes for a late actually failure of the case is many of the times in the pars plana region, especially when we do it in cases where we do a lens sparing vitrectomy, like endogenous or something like that, where you preserve the vitreous in the periphery, where you can't go exactly in the pars plana region or the vitreous base actually. So there it contracts after some time, it causes detachment of the ciliary body, it forms a cyclitic membrane, and many times we lose this case because eventually the patient goes for hypotony and then eye goes into phthisis. So when you talk about these near total complete vitrectomy, these vitreous based dissection actually is very important. That's what.
Like I said, I do look at the case. If I feel the retina is very inflamed, I won't induce a PVD and do a complete vitrectomy, but I will just induce and tease it, PVD, and then kind of probably inject again after a couple of days. But otherwise, if I feel the retina is not that inflamed, depending on case to case, I'm like,
But I will always be very careful. I mean, like if I create a break, then I am.
And one more thing, ma'am. What about the silicone oil insertion after this vitrectomy? Any indication for that?
See, in some cases where you feel like, okay, I mean, there are various studies which have shown that silicone oil injection at the end of the endophthalmitis has got a role, both like an anti-infective, and in case if it buys you some time to re-intervene. Suppose if you have created a break in the periphery and you have missed it, then it gives us some time for a second intervention. Otherwise, we will lose that eye because it may rapidly progress for a closed funnel RD.
and the oil also has a bacteriostatic action, so it is preventive, helpful in that condition state.
Thank you, Rahul. So thank you one and all. So we will wind up this session.